I am a reproductive endocrinology and fertility specialist coming to iPad because I can't get the computer to cooperate today, and Tarek is not with me. Fertility Fact or Fiction, our weekly show where we answer all your questions and usually review a top interesting topics this week. So it's all questions. So feel free any questions you might have. We are here to answer them and raring to go. Yesterday from the Ministry of Health in Ontario, we can now officially put this out there. We have received from the government to provide IVF care for the patients, and super excited about that, and hoping that that'll make a huge difference. And so we're really excited to be able to do this for everyone. It's enough to people in the area, and so every year now everyone will have of getting IVF care than they ever had before. So very, very cool. We are that to you guys. Tarek is with us, but he is at a right now, and so he is going to be doing this from afar. So you have all of the questions, and I don't know if I'm going to be able to hear you or not, but questions, there you go. And I am going to try and jump on from the computer again, muck around with the audio. So let's try that. How's that?
I think you're okay.
Okay, hang on. Let me log out on this other one. Okay, there we go. Hopefully that's better now. So I'll switch the audio over. Yeah, it should be good. I think you've got everything you need. So welcome back. And we've got some questions. Ola from Puerto Rico. Ola, Dr. VNT. My husband was prescribed Clomid every other day for 2 months because of some labs our doctor had him do. The following labs and results: testosterone 327, FSH, prolactin, TSH. So is there more to that question?
Yeah. It goes on to say prolactin 4.9 nanograms per mil, TSH 1080. Would you recommend that protocol? He's also taking some male fertility supplements. Gracias.
Yeah, I mean, the testosterone isn't in our units, but off the top of my head, that's kind of borderline. So Clomid will help to make more in more testosterone, and by making more testosterone, it'll produce more sperm. So that's very reasonable. I would certainly think that that's a reasonable approach to things. I wouldn't necessarily do anything very differently. So yeah, I think that's a fine way to go.
And I have some questions for you, Rahi, in the chat for us from Instagram. I'm going to.
I see that. Hi, both. My FET is coming up next week, and my TSH is shot up to 5.5. I'm on levothyroxine. Should I postpone the FET? Yeah, that's a little high. I'd prefer to see your TSH come way down. You probably could get a good response if you just get on the right dose. So if you've got enough time next week, you probably have enough time to get it under control, but that is high. Keep in mind that your thyroid is most important for the neurodevelopmental outcomes of the baby, less so for anything else. So I don't think there's any problems with you getting on the right dose. Does it matter what day you start injections if you're on estrogen patch? My clinic is fully booked until cycle day 4, and I'm worried. Yeah, it matters a ton. Patients with weaker ovaries should start on cycle day 2. Patients with stronger ovaries, cycle day 3. We never start on cycle day 4. So if your clinic is too booked, then they shouldn't be taking patients. That doesn't make sense at all. So yeah, I would definitely get that checked out first and decide what the right approach is for you.
Go somewhere that isn't packed per se. How about going back to these other questions? So excited about the funding news. Will we get an appointment with you before we get our call for the start of our IVF cycle to explain everything? So the funding allocation is based on a wait list. And because people had been waiting so long for funding in Windsor, there's already a wait list. So feel free to call the clinic, find out, if you're eligible and where you're at on the list, if you're on a list. But as far as whether you're not, you're going to get a spot right away, it's already waitlisted. So pretty much all of this year has already been allocated to people that were waiting several years. So definitely get in touch with us, but hopefully there's enough to spread the joy. So yeah, we'll do our best for that. What TSH do you prefer prior to embryo transfer? Is it mandatory for the patient to get on thyroid medication, or can the patient opt to only take the thyroid medication if TSH is above 4.5? So both ASRM and the Endocrine Society stipulate that you should get your thyroid level to be less than 2.5. So 4.5 is too high for sure. We definitely want it less than 2.5. Is it mandatory? Nothing's mandatory, but I mean, it should be, because you want to optimize your success rate. So that's a very reasonable approach. YouTube. I love YouTube. Hi, T and Dr. V. My doctor added baby aspirin to my stim protocol, and I'm curious about why this may help during stims. Thank you. Love listening every week. So aspirin, we have a whole really good video on aspirin. Improves your blood flow, may increase the egg number, we're not sure, reduces complications in the pregnancy, reduces inflammation. So there's a lot of benefits to it. Prevents clotting, and if your estrogen level is going up, that can be a problem. So there's a lot of benefits to using the aspirin. I'm going to go back and forth. So if you guys see my eyes playing, eyeball Wimbledon, that's why. Okay. Hi, Dr. Victory. How does one qualifies for the IVF funding? So you got to be a resident of Ontario. The woman has to be less than 43 years of age. And then we have clinic specific factors that we are looking for. So depending on your age and what you've done before, and whether or not the sperm is good enough, are your tubes blocked, is there severe endo, and so on, we will prioritize people as best as we can to kind of get out to everyone as much as possible. What up, T? Oh, I like that one. Yeah, that's why you put that one up there. Hey,
I can't help myself.
I saw a specialist, and after histo, I'm assuming that's hysteroscopy, said my lining looked great, and trilaminar about 5.5 millimeters. How thin is too thin for FET? Any success with thin lining? So less than 7 millimeters, there is a decrease in success for sure. So you definitely want it higher than 7 millimeters. So 5.5 is thin. There are successes, but the chances are going to be much lower than they would be otherwise. Let me jump back to here.
There's a great.
What's that?
There's a great question. The phrase and the wording is really on Facebook. You'll eventually see it.
I'll get there. What TSH do you prefer? Oh no, that's the one we read. What TSH is suitable in early pregnancy before FET? 2.5. How long does it take when on a new dose of thyroxine? It can take a week or two. It usually takes about a month for it to stabilize. So you don't need to get down too low. If you're at 3.1, you just need to drop down below 2.5. That probably wouldn't take more than a week, even on a low dose. Hi, Dr. VNT. I have started my injections for IVF, and it has made me feel very sick. Oh, I'm sorry. Any recommendations or tips to make it through the rest of the injections without feeling so sick? I would make sure you're not on a huge dose. I would make sure you're injecting it the right way. I would make sure that you're using the right medications for you, and then talk to your doctor. Sometimes if we give you really high doses, it can make you feel ill. So that would be important. We are on the list. I talked to Sarah today. Okay, Jackie, that's great. I was just wondering if the clinic will call us prior to starting the IVF cycle, or do I have to call and book that appointment with you to go through it all? You can do it with Sarah. So just chat with Sarah about it. You're welcome to talk to me anytime. So if you want to chat with me, that's perfectly fine. Not a problem. Should I be taking baby aspirin basically continuously? Yes, you should be taking baby aspirin continuously.
Now you see it. Now you see it.
Hello, Dr. B and fertility intern, Dr. T.
It deserves a standing ovation, to be honest.
That's a standing ovation. Bravo. What causes one to have weak ovaries / DOR? I'm a younger, healthy female, as is my husband. I have low AMH, 0.7, no units. Guys, always give me your units because I don't know if you're Canada or the US and they're different. High FSH, 20, and low AFC, 6. I'm currently 35, but when I started all of this, I was 32. I've done 4 rounds of IVF. Wow. Standard IVF, duo-stim, and natural cycle, all with you. And I just transferred my last 2 embryos 2 weeks ago, and my FET failed. I am sorry. I only ever got a few embryos, and those died. And the 2 that can be tested came back complex abnormal. I know we have to move on to donor eggs, but I still just wonder how my numbers were so bad in the first place. I don't drink, smoke, or do drugs. So first of all, I am so sorry you went through that. That's terrible. And I feel for you for sure. Why does it happen? We don't know. A lot of it is genetics. Some of it is environmental exposures, chemicals, plastics, toxins. Even makeup and stuff like that, more and more they're realizing is not great. There is, exposures in terms of illnesses. There's your immune system, your risk of having things like autoimmune conditions can increase your risks of DOR, diminished ovarian reserve, smoking, drinking, drug use. Obviously, you said you don't do that, but if you ever did in the past, weight can be a big factor for some people. That can really mess things up as well. So there's no way for me to tell you exactly what it is, but it depends on what's going on. Everybody's different, but there can be a lot of reasons, and probably the biggest one is genetic. Why do chemical pregnancies happen? Wow, that's a great question. Chemical pregnancies happen because typically there's either something wrong with the embryo, which is going to be most common, or there's something wrong with the host. So either there's a problem with the quality of the embryo, or there is a problem with you that is preventing the embryo from developing. And so it'll attach and it'll start, but it won't be able to continue, and that can be a problem. Hi, Dr. V. Thank you for taking the time to be with us. Which is your preferred and why? Estrase or patches, PIO or permetrium? No estrase, no patches. You want to avoid estrogen, use letrozole. If you have to use it, we use estrase, but I don't think it makes a difference. PIO or permetrium, both. You should always be using both. Thanks so much for your efforts in getting funded IVF in winter. Yes, I love the fact that we got funding. We all worked very hard on that. Tarek helped as well. So it was a group and team effort, but we got it, and we are very, very proud of that. So very excited. Hi, Dr. V. I saw you on Sunday for my egg retrieval. I almost screamed. Nice to meet you. I have pains, bloating, and I feel gassy. I have an ultrasound tomorrow. Should I be worried? No, only if you think you're getting hyperstim, which shouldn't happen with our trigger. So if you feel like you're bloating, short of breath, your pain is increasing, let us know. But otherwise, gassy is pretty normal. Don't worry about that. Let's go back to this side. Hi, Dr. VT. Hi, Team VT. What are your thoughts on HCG infusion just before an embryo transfer? 15 minutes before, it's about a 30% increase in your chances of success. So we do it all the time if we've had previous failures. It's a very reasonable thing to consider doing. Hello, Dr. Victory. I'm a dual stim patient of yours. I've completed the follicular stage of stim and egg retrieval. However, I was not a good candidate to proceed on to a second round of stimulation for the luteal phase, and thus could not capitalize on a secondary recruitment of follicles in a single cycle. Now, from what I've read, the second wave of follicular recruitment is potentially stronger and better than the first, yielding not only more eggs, but better quality and more mature eggs. My question is, am I at a disadvantage due to not being able to? No. So we do what we call split duostim all the time, where we just stimulate you in your follicular phase. We actually get more eggs, and the quality seems to be even better. So you are not at a disadvantage. You're perfectly fine, D. So I wouldn't worry about that at all. I really like split duostim. We kind of pioneered it, and it works really well. 2 chemical pregnancies, and the last one was using a tested embryo, no clotting issues, autoimmune issues, good lining at 10 millimeters each time, and cannot get beyond 4 weeks pregnant. Help. This is from Gia on YouTube. Gia, that requires a whole discussion. So I need to know what's wrong. I need to know your whole history. I need to know how we can make it better for you. I need testing. I need results. I need to figure out exactly what's happening. I need your history, your partner's history. I can't just help. I'd love to, but it doesn't work that way. I need lots of details. So contact us. Type in info@drvictory.com. Maybe Tara can put it up there on the screen somehow, and just ask for a consult with us. So info@drvictory.com. What does a FET cycle look like for someone with endo, and how does it differ from someone without endo? Hey, Carly. Yeah, so Lupron and Letrozole first, then just Lupron, then just Letrozole. And we try and use little to no estrogen. Otherwise, it's basically the same. There's a recent study I'll probably review next week, which suggests that for endo patients, you should keep the progesterone levels a little on the higher side. So in our units, we always aim between 40 and 100. And American units, that's 10 to 30. So we're probably going to push those patients closer a little bit to the 100 rather than the 40 to try and get the best result possible. Back to private chat. I have some small fibroids in uterine lining, but none inside the cavity. I recently had another donor embryo transfer. My HCG did not progress past 37. Could my fibroids be the issue? Depends how big they are and how much they're indenting the cavity. If they are, I'd be looking for other things as well. If you had donor embryo and it didn't work, you need to know about the quality of the embryo, but you also need to look at the protocol they're using for you. What medications you're on, or did they give you estrogen? Did they not give you estrogen? If you have fibroids and you're taking estrogen, that's definitely not a good idea. It's like fibroids and endo. So there's a lot there that needs to be considered. So yeah, I would definitely want to know sizes, locations, get a saline infusion sonohystogram, look at your protocol, look at the quality of the embryos. We do a lot with Fertility to test the lining and test your immune system. That can help as well. Hey, Dr. VNT, we love you guys and appreciate these lives. I look forward to it every Tuesday. I have no idea who you are, but thank you. That's very lovely. All I see is it says host, so my apologies to all our IG friends out there. How often do patients start out an embryo transfer and have a good TSH, but when they are pregnant, the TSH rises enough to require thyroid medication? It's not very often that if you're euthyroid before your embryo transfer on no medication, that you'll need to go on thyroid medication. But anybody that needs thyroid medication will need more of it while they're pregnant. So that's virtually everyone. Is it safe to take melatonin before and after an embryo transfer? Not only is it safe, it is highly recommended. It is a big increase in your success rates. We have a show on that. It's from years ago, so you should take a look at that for sure. Hi, Dr. V. What is the timeline of embryo transfer after finishing the 3-month Lupron suppression? Do you have to do more suppression if future transfers fail? It depends on how many transfers you do and how much estrogen we expose you to, but we usually roll you right off your 3 months into your FET. So there's no gap between doing your suppression and jumping into your cycle. And then depending on how many times we do cycles, God forbid it be more than 1 or 2, you may require repeat suppression, but we really try hard to avoid that. Hi, Dr. VNT. How many intralipid infusions does it take to sufficiently reduce high NK cells, and how far about should you have the infusions? How far apart, I guess they meant. Thanks. That's for Cassandra. So, 5 to 10 days before your embryo transfer, day of the embryo transfer, at the 2-week positive beta, obviously, if it's positive, and then at 6 weeks. And then we continue every 6 weeks till 34 weeks. Some people stop after 12, so it's kind of up to you. So 5 to 10 days before, day of, 2-week mark when you get a positive beta, and then the 6-week mark, and then some people continue. Beta HCG went from 5,000 to 20,000 in 8 days. Oh boy, I got to do mental math here. So it would have to go to 8,000, and then from there it would have to go to 12,800. Yeah, that's not bad. Went in for my 6-week scan and saw yolk sac and fetal pole. Fetal pole had heart rate flicker. Fetal pole measured 2 days behind. Concerning? Absolutely not. Not concerning at all. Congratulations. Everybody throw some applause. That's awesome for you. How many hours a week do you typically work, Carly? Somewhere between 80 to 100. So I work about 80 to 100 hours a week. Between call and all this social media stuff and everything else, I work a lot. But I love what I do, so it's a good life. I've been dragging Tarek into it more and more too, so he's working hard as well. I'm 44. I wish I was 44. I am not 44. The person that's writing is 44. I'm 44, have done 3 cycles of IVF, and typically make about 3 eggs and 2 embryos. Hour of about 8 to 9 baseline follicles. Okay, so I'm assuming they get 3 eggs out of 8 to 9 baseline follicles. So far, 2 chemicals. They have not done PGT, and 1 didn't implant. We aren't ready to give up and are considering banking as many embryos over to 2 to 3 cycles as we can for a last try at this. Should we do duo stim? And if so, can we start the next cycle right away? Yes, you should probably do duo stim, but I would need to know more about you. At 44, no matter what you do, it's going to be difficult. I would argue that for PGT in that stage, because it'll help guide you in terms of should you do more cycles or go to a donor. So for me, that would be important in your case. Do you think using at-home Dopplers at 13 weeks for occasional reassurance is a good or bad idea? I love all of you guys, but it's a terrible idea. It just makes you anxious and nervous, and you won't have the skill set required to find the heartbeat every time. It will drastically increase the chances that you end up going to the hospital and making you panic for no reason whatsoever. Do not rent them. Do not buy them. Do not use them. I wouldn't do that. Okay, so $8,000 signs. I'm not sure what the significance of that was, but that's okay. Hi, Dr. VNT. Thoughts on freezing on day 3? We lose most and sometimes all of our embryos between day 3 and 5. Yeah, I mean, if you're always losing your embryos, I would freeze them on day 3 and do day 3 transfers. That's not an unreasonable thing to do. I think that's a great idea. Do you recommend letrozole or Clomid in addition to Gonal and Menopur in women over 43? We recommend letrozole. We reviewed that on the show it's probably 2 months ago, T. I don't remember. It's got about 600 views. So look it up on our YouTube channel. It's called letrozole and something. T, can you pop up the thing for that, or is that not possible with what you're doing?
I think I can pop it up for you. Yeah. I'm just looking for it right now. Yeah. I'll eventually pop it. Yeah.
Yeah. So yeah, we would recommend letrozole. Gonal and Menopur is great. We use a lot of Recavel in our older women. That's also great. I have both methyl tetrahydrofolate reductase mutations. How the heck? Anyway, my regular OB says take baby aspirin, and 2 fertility doctors have said no reason to take it until pregnant. What do you suggest since I am starting IVF? You have to take baby aspirin before you get pregnant. And you have to take it, you should take heparin and then folinic acid as well, especially if you're homozygous mutated. For your actual retrieval, you are at a higher clotting risk, so I would be cautious with that. That's the video. Thank you very much, T. That's excellent. So it says letrozole, should you take it? So definitely watch that. That's important. It's on our YouTube. Transferring November 17th, my only 1 embryo, okay? I don't know how they know it's November 17th, but that's okay. Is there concern around being around others with Thanksgiving? Only if you get COVID, in which case you shouldn't transfer. What are my chances of successful implantation? PGT normal, I assume they mean 4 BC, not 40 BC. Did Lupron 2 months for endo. So it's a BC grade embryo, you're 40 and you have endo. Off the top of my head, probably somewhere around 30 to 40% chance of a live birth from that. I'd have to know more about you, but that would be a realistic expectation. First time I had my AMH drawn, it was 0.45. Second time I had it drawn 4 months later, it was 1.04. How good of a candidate do you think I am for IVF? No way to answer that without knowing way more about you and your partner. And I don't know what units you're using. So if that's picomoles, it's definitely not good. If it's nanograms, it's okay. But I need to know a lot more about you before I can answer that. Okay. Hi, Dr. V. Just saying hello. And I love and appreciate all you've done for me and so many others. Hi, Jamie. I love you too. Thank you for watching. You're a sweetheart. What is your opinion on Gonal-F versus Menopur? I'm PCOS and can't seem to produce good quality embryos on Gonal-F. Doctor wants to try Menopur this time. Do you think it will make a difference? I'm 27 years old. Yeah, so you actually should be using both, especially when you're PCO, because you need some LH activity with the FSH activity, and the beta HCG that is intentionally contaminated into Menopur actually provides you with the LH activity that you need. So we always use both, in particular in the PCOS population. If you're doing it with IUI, Cassandra, then I would say just use the Menopur alone. If you're doing it with IVF, you should be using both for sure. I think that's it on that side, dude. Okay, back to Instagram. Hey, Dr. V, I was just curious of the cost of transferring remaining embryos resulting from a funded IVF cycle after a successfully completed cycle. So if your question is you had a funded IVF cycle, you made a bunch of embryos, you transferred one, you got pregnant, and now you want to transfer another one, the total cost of that is free. You don't pay for any of the embryos from your funded cycle, no matter how many times you want to get pregnant. So we have to do all of the embryo transfers. So it's totally fine. You can do that as many times as you want until your embryos are done from that cycle. Why did my double methyltetrahydrofolate reductase not affect my successful live birth pregnancy? I have no idea. I'm very lucky. I didn't take extra folate. It's not extra folate. You need to take folinic acid instead of folic acid. And my prenatal at the time, which had folic acid, miracle or luck, it's miraculous luck. It's both of those. Tips for my 6th embryo transfer. Wow, please, last embryo. Total bed rest or not? Prednisone. Wish me luck for this FET. Don't transfer till you have a reason why your other 5 didn't work. That's the tip. So don't just jump into another transfer. You have to know why the first 5 didn't work. And if they're not giving you answers, just transferring again never makes sense. So don't do that. FET failed, didn't even implant. It was PGT egg embryo, good quality, progesterone 39, estrogen 700. Why do sometimes they don't work? Should I be worried about another transfer not working? You know, PGT normal embryos only stick 50 to 60% of the time. So you don't have to be worried. It's always worth doing more tests if you don't have a lot of embryos. So, you know, you can talk to your RE and figure out what's wrong, but you don't have to test if you don't want to. It depends on how many embryos you have. If you have 5 or 6 left, I would just do another transfer. But if you only have 1 left or 2 left, I'd probably do the testing first to make sure we maximize the chances that we're getting this perfectly right. Over to Sarah from Facebook. Hi, what procedure would you recommend for a couple with severe male infertility with over 75, wow, over 75% DNA fragmentation? We've done TESA as well as ICSI. No smoking, no drinking, no drug use. That's 100%. If he's heavy, drop his weight a lot. I would make sure he's ejaculating every day or every other day. Take loads of fertility vitamins. And then here's the best advice I can give you. get a first sample, and then 3 hours later ejaculate again, the second sample has 80% less DNA fragmentation than the first one does. So Sarah, that might solve your problem, hopefully. Also reach out to us. I mean, we're happy to help. And we have another great video, Tarek, you can put that one up too, for what the 4 best ways to improve sperm are. So just check that out and that'll review it for you. Hi T and Dr. V. Post-retrieval baseline ultrasound showed a large avascular area near an ovary. Doc is unsure and said could be bleeding or blood clot. What does this mean for the timing of next retrieval? Not much. Yeah, it's that first one right there, guys. Top 4 ways to improve men's sperm. It's under the Fertility for Men part of our YouTube channel. So check that out for sure. Yeah, I don't know. I mean, I think that if there's something there, they got to make sure it's not an infection. This is for Sarah V on YouTube. As long as it's not an infection, you're fine to go ahead. If it's looking like it could be an infection, that's serious. So I would hit the brakes and get that checked out first. So make sure you're careful about that. Leah on YouTube. Hi, Dr. V. I'm 40 with DOR and husband has low motility. How many IUI with letrozole should I do? 3. I did IVF. Oh gosh, sorry guys. Tarek, are you still there? Yeah, sorry about that. I'm 40 with DOR. Sorry, how many times? I got 1 blast from IVF. It didn't implant. I can't do IVF again. So IUI over the age of 40 should only be done 3 times. After that, it's got a 0% chance of success. So don't do that. Okay. Typically, how long after your egg retrieval would your FET be? What is the protocol beforehand? So we usually space it out about a month to 2 away from your retrieval, just for logistics. The protocol, okay, so Lupron cycle day 21. We do this every show. Letrozole day 3 to 5, antibiotics and probiotics to follow, melatonin, vitamin D, iron, and then depending on what your diagnosis is, other things if necessary. Monitor your lining. Once you get to 8 millimeters, start progesterone in oil and vaginal progesterone. Monitor your levels after 3 days. Make sure they're in the right range. Wait 5 days for a day 5 embryo, 6 for a day 6 embryo. That's our protocol. When would IVIG be required or good to try? So IVIG, which is intravenous immune globulin, is something that we use for patients with specific immunological problems. The problem with IVIG is it's insanely expensive. And when I say insanely, I mean truly insanely expensive, $5,000 a treatment. So I would say that you really only need to consider that if you've exhausted every other option. We do use subcutaneous IG therapy here, and I love that because it's free. So if you're in Ontario, we can do that, and that works out really well. Dr. V and team, thank you for all that you do. Well, thank you. Thank you for watching, guys. Hi, Dr. V and T. If you shouldn't transfer if you have COVID, what does that mean if you get COVID and are in an IUI cycle? Oh, that's a good question. It's got a lower chance of working. If you don't mind the cost, I probably wouldn't stop it from going ahead. But if you're worried about the cost, then don't do it because it could be significantly decreased chances of success. So the reason we say no for IVF is the cost and the limited number of embryos. But IUI is not as big a deal, and our costs for IUI are really low. So for us, it's not a huge issue. We don't refuse it to people with COVID or recent COVID. Oh, here's a great question. Hi, Dr. V and T. How long after a miscarriage should you wait before trying to conceive? Tarek, do you want to take that one or should I? You're apparently my medical infertility intern. You don't need to wait. You can go ahead at any time, guys. So as long as you get a period, you're fine to go ahead. I love that intern thing. That was funny. I'm going to get him a t-shirt that says my medical intern. Some thank yous from some of the people we responded to. Carly, how many transfer cycles would you do until moving towards surrogate or egg donor? Oh my God. God, these kids are calling me. Sorry. My kids need to learn that I'm on a show. I would probably say 3 or 4 transfers in someone that has enough embryos. Carly and you, because you're young and healthy, at least 3 or 4. Okay, if supplementing progesterone, do you need to increase the dose as you get further along until it is stopped? No, not at all. In fact, the opposite, because as the pregnancy takes over, you don't need as much progesterone because the pregnancy itself starts producing its own progesterone. So that's not needed at all. Okay. Hi, Dr. V. Mute the kids. Mute the kids. I did mute the kids. Unfortunately, it's the FaceTime on my computer that keeps starting. So I will tell the kids to stop calling. Here we go. On the show. Tell your brother. Okay. Hi, Dr. V. My husband and I are both 35. We have DOR and male factor. Our protocol for our first retrieval was a moderate dose of Menopur and Gonal-f, which resulted in 2 embryos. Good. Our protocol for our duostim cycle was a low dose of Menopur, Gonal-f, and Sison, which resulted in 1 day 7. And our protocol for our luteal phase was a high dose of Menopur and Puregon, which resulted in 0 embryos. All embryos produced have been poor quality. We are doing 1 final retrieval. What would you recommend? Okay. So DHEA for 3 months. And I don't know enough about you, but rough estimate here, rough guess without knowing anything. DHEA for 3 months, Sison for a couple of weeks before and through your stim. Not a crazy dose, maybe 187.5 of Menopur and 14 or 15 units of Recavel, or let's say another 187.5 of Menopur, of Gonal-f. We do a microdose flare protocol for you, double trigger. And we would trigger you when you have like 20 millimeter follicles, 19, 18, that kind of size. And then wait 5 days and start your duostim only if there were enough eggs. If there aren't enough eggs, don't bother. Wait till the next cycle. Trigger your follicular phase egg when it's an 18. Wait 5 to 7 days and then start your luteal stim. That tends to work really well. Use GM CSF media. Make sure they use ionophore oocyte activation. There's lots of ways to improve this for yourself. Do you recommend human growth hormone for priming or during stims for women over 43? I found out I had a low level of endometriosis through laparoscopy 2016. Yeah, we do. We use Sison or Omnitrope for lots of our patients, especially if you're older. So there is some evidence that it improves the outcomes. My last pregnancy ended at 18 weeks due to baby having triploidy. Oh, I'm so sorry. Is it true that most of the time triploidy is caused by an egg being fertilized by 2 sperm? How likely is triploidy to occur? Yes, either the egg came as a diploid, or you got 2 sperm in there. Although that's usually something called a mole, which is different. How likely is it to recur? If it's a mole, then it is likely to recur because you have a partial mole. So those have a reasonable chance of recurring, and you need to be very cautious with that. If it wasn't a mole, and when I say mole, I'm talking about something called gestational trophoblastic neoplasia. If it was not a mole, it's probably got a very low chance of recurrence, maybe 1 or 2%. Thoughts on mixing meds with a microdose Lupron flare protocol to reduce shots? For example, MDL, microdose Lupron in the morning, then Menopur fall stim and MDL in 1 syringe. Or is that a no-go idea? That's definitely a no-go idea. Don't do that. That's not a good idea at all. Hi, Dr. V. I'm 43. TTC naturally and had a chemical at 4 to 5 weeks. I'm sorry. AMH 2.56. Oh, that's good. I'm still trying to consider moving forward with IVF. What are realistic expectations for IVF success with live birth? Watch our video called Embryo Math on YouTube. Per cycle with an AMH that high, I'd probably say you are likely, with us, probably going to get somewhere around the 30 to 40% success rate. per cycle. So it would add up to be pretty substantial. In an otherwise natural FET cycle, my clinic uses an HCG trigger. Is this necessary? Good, bad. Going to ask about adding letrozole next time. Do you use a trigger shot with that protocol? We don't normally trigger our letrozoles. We don't need to. So we don't do it, but there's no harm in doing it. It does help fix the timing of your embryo transfer a bit more precisely. So it's a reasonable thing to do. It does mess up your progesterone levels a bit. So you got to be a bit more cautious. Carly, why isn't endo considered an autoimmune disease? Well, it's not exactly autoimmune, but it has features of autoimmune. So arguably it should be. People are always discussing whether it should be considered like a pseudo malignancy or an autoimmune condition. People have enough time just agreeing on definitions in fertility. We're never going to get them to agree on whether endo is autoimmune or not, for sure. Hello, Dr. V and T. Thank you. I have 2 endometriomas in both ovaries, 4.6 and 1.4 centimeters. I have AMH 1.5 USA units, that's nanograms per milliliter, and 33 years old. What are chances of me having a natural pregnancy? Oh my God. There's a million things that go into that, but your chances are lower than they would be if you didn't have the endometriosis. That's all I can tell you. That 4.6 is very large. That should be considered for surgery, in my opinion. Hi, Dr. V and T. Actually, it's T and Dr. V. T, you came first in that one, buddy. What are some key topics to cover during a first consultation with a new RE? You know, that's a great question.
Should I try and answer it?
Do you want to try and answer that one? Yeah, sure.
No. That's for you. That's for you.
That's for me. Okay, so I would say ask how many years of experience they have. Ask what the last article they read was. Ask how often they change their protocols. Ask what they know about stuff that we talk about here, like do they know how to run a duostem cycle? Are they using a double trigger? Are they using a letrozole protocol? Because if they're not staying current. And those are things that are easy to figure out. So I would ask them. Okay, I got to go backwards because there's a question that's being asked from someone, but I don't see where her original question was at all. Someone said, "What about IVF?" But I don't know where the original question was. I don't see it anywhere. Do you see that one from Bora?
It's the one right before it. It's a continued question.
Oh, okay. Oh, I see. What about IVF? Yeah, IVF would help you, Bora. So this is the lady with the endometriomas. IVF would definitely help you, but you still need to deal with your endometriosis. So don't just get suckered into doing an IVF cycle. It's not about that. It will improve your chances, but you still need to deal with the endo. Is it true that it doesn't matter if endometriosis is improved by ablation or excision? I read that it is more likely to come back if not excised. Yeah, so that's not true at all. There's a whole bunch of people out there that think that you absolutely must have excision. It's not true. There is a 1-point difference in pain between excision and ablation. The only time it makes a difference is if you have something called DIE, which is infiltrating endometriosis, where it's like penetrating into the tissue, then you really want excision. But otherwise, ablation or excision is the same thing as long as you destroy it. So yeah, you don't need to have excision surgery. You can have ablation surgery. Let's look back to the gram. Thank you so much, Dr. Victory, for being superb. Oh, and be so kind all the time. You and T. Oh, and T, you are awesome too. Yes, he is. I love T. He's a good guy. I'm kind of sad he's not here with me today. Dude, you broke my heart. And no warning too, man. That was cold. I felt it right here. Hi, Dr. V and T. What should natural IVF look like? What to take? 31 years old, low sperm count and motility. Failed fresh transfer day 3, or we are going to redo it. Monitor your natural cycle. when you get to like a 13 millimeter follicle, start Cetratide and 1 vial of Menopur, 75 units. Continue that until you get to about an 18 millimeter follicle, roughly. Trigger at 18 and get the egg and turn it into an embryo. There's nothing wrong with doing a day 3 transfer in that situation, although we still grow them out to day 5, and sometimes we do PGT. Should you wait till day 5 this time? Yeah, I would. Hi, Dr. V. Had a miscarriage on my 13th week. Oh my gosh, I'm so sorry. About 6 months ago. However, we've been trying again, but no pregnancy yet. Can we do microscopic insemination? I think they mean insemination. Can I get your opinion? Choice Mama Adventures profile picture. I have no idea what you mean by microscopic insemination. Maybe just clarify that one for me. 37 with DOR, 2 rounds of IVF with mini IVF protocol. Would a microdose Lupron protocol be good to try next time? You know, I have a lovely couple who's here in town now from the US who had not so great stims before and followed our protocol. And she's doing amazing now. So yeah, there's nothing wrong with doing a microdose flare. For some people it works really well. And so we use that all the time. Would a double trigger be beneficial even if you're not at risk for OHSS? Yes. Double triggers result in higher pregnancy rates, higher live birth rates, more mature follicles, better quality embryos, always double trigger. What is the best frequency for progesterone during a letrozole protocol? And when does progesterone supplementation start after LH surge? So usually you'll start somewhere between 3 to 5 days after your surge. And we go daily. If it's a natural surge, it's hard to titrate the progesterone because initially your progesterone is going to go up naturally and then it's going to come down. And so you've got to kind of go low first and then go up as the progesterone naturally is coming down. Hi, Dr. V. I had canceled cycle with you this month after 2 days Menopur and gonal injections. Is that anything I can do to improve the follicles? Thank you. Acupuncture, naturopathy, DHEA, human growth hormone, testosterone priming. We might try a different protocol for you, all of that stuff. Which Apple Watch do I have? I have an Hermes Apple Watch because my wife and kids bought it for me for my birthday 3 years ago, I think. So that's the Apple Watch that I have. I am a watch fanatic. So if you've ever watched the shows, guys, you'll see me wearing different watches usually. Tarek and I both love watches. So I have a few. Do you have anything that you put on the embryo dish to help the embryo grow? Yes, GM-CSF media we use. We use oocyte ionophore activation. That's not in the embryo dish, it's in the egg dish. So all of those can work. And then whatever other magic my embryologist and lab director are doing there, I don't know. I leave that stuff to them so I can do all the clinical stuff that I need to do. Is there a higher or same chance for transfer after a failed FET? It depends on the reason for the failure, but it should be the same chance as before. I heard you say to double trigger on a microdose flare. I was told you can't do that because you're already on Lupron. That's not true. You can. We do it every time. So if you're on a flare protocol, you can still use the Lupron trigger. We use a little bit more HCG though, and that's okay. Thank you for your solidarity with Iranian women. You are amazing. Listen, some of you probably saw my post about Mahsa Amini in Iran. If you don't know it already, I am a member of the Baha'i faith, and Baha'is are persecuted in Iran. So to see an innocent, very young woman have her head bashed in because she wasn't following the law is a lot to stomach. I am all about following the laws. As a Baha'i, we are told to follow the laws. I think everybody should follow the law. But justice should also be merciful. And to bash a 22-year-old woman's head in for not following the law is not okay, no matter who you are, where you are, or what you did. So yes, I am totally in solidarity with the people of Iran who need to overthrow that psychotic regime and end what has become completely corruption and nothing else. And I'm not usually political, but you know what? A lot of innocent people of every faith, including many, many, many Muslims, have died at the hands of a bunch of nut jobs in Iran because they're not doing it for religious reasons. They're doing it because they want the power and the money, and that's not okay. And that's not what any religion is about. Most of all, Islam, which is not about that at all. So I have nothing but respect for Islam. I've read the Quran twice. It's a holy book, and we revere Muhammad, and Muslims and other religions as well: Christianity, Judaism, Buddhism, Hinduism, all of them. But what they're doing is none of those. It's just savagery, and that's not okay. Can you drink dandelion root tea while doing IVF? I am not a dandelion root tea expert, so I have no idea. I will look it up for you, though. I can't understand why anyone would want to drink dandelion tea. Is it good? I want to know if it's good. My blood type is O negative, and my husband thinks he's O positive. I've heard of Rh compatibility being an issue in pregnancy. Can I have more info on this? Yes. If you are Rh negative and you are ever exposed to Rh positive blood, so you actually have to share a needle, or you have to have had a miscarriage of an Rh positive baby, or the delivery of an Rh positive baby, and there's an interaction of, or you got a blood transfusion by accident, and you have Rh positive blood enter your Rh negative bloodstream, your body will mount an immune response against the Rh positive blood type. It's not a problem in that pregnancy. It's a problem in the next pregnancy, where your immune system will remember the Rh positive blood type. And if it sees it, even in the baby, it will attack. And that can be a disaster. So as long as you've never shared needles, had a blood transfusion, you're not what we call isoimmunized, so sensitized to the positive blood type, it's not a problem. But if you are sensitized, it's very much a problem. Was previously asking on chances of transfer 4 BC. Yeah, I got that. Embryo with endo. So the 4 BC 32-year-old, that still has a pretty decent chance, but the endo cuts it down a fair bit. So I would go on an endo protocol to improve your chances. That would bring it up to probably somewhere around 50%. 13 weeks this week. Yes. Should I be taking baby aspirin every day? Yes. Is this just for reduced chance of preeclampsia and preterm labor or miscarriage? Yes, yes, and yes. Absolutely. So baby aspirin reduces preeclampsia. It probably reduces miscarriage, and it does reduce preterm labor as well. So use it. Do you recommend taking baby aspirin during stims? Yes, I do. Absolutely take baby aspirin during your stims. Hi, can you please explain about mitochondrial replacement therapy? I know it was approved in the UK. Okay, so the mitochondria in a woman's egg is the energy source for the embryo. So if the egg is old or not great quality, part of that might be because the energy source is not working well. So if in theory you replace it with better quality energy sources, it may improve the outcome. Very poor data on this. Very weird to mix somebody else's mitochondria with your genetics. We have no idea what the long-term outcome of this stuff is. It was tried years ago by a company called Oviscience in a procedure called Augment, some of you may have heard of, where we found supposedly mitochondria from stem cells, which were supposed to be better. And you did the ICSI with the mitochondria in with the sperm, and then you looked to see if it improved the outcome. We got 1 out of 5 people pregnant with that approach. So that is not an ideal approach to things. Okay. If I've had 4 transfers, 2 out of those ending chemical, I'm 28 years old. Is it time to give up on having a baby? Unexplained infertility. No, it's time to figure out what's wrong, Gia. So talk to us and we'll figure it out. And there's lots of tests we can do. So we can usually help you with that. Reach out to us. info@drvictory.com. Tarek, you got to put that up, bud. Hi, Dr. V. We did a modified natural and it failed. Oh, I'm so sorry. I did only vaginal and oral 3 times a day. I'm assuming they mean progesterone. And 2 times a day by mouth. Do you think the next round we should do progesterone and oil? Yes, absolutely. You should do progesterone and oil and vaginal progesterone. By mouth, you only get 10% bioabsorption, so that's useless. So don't do that. Oil and vaginal, and then I would need to know more details about everything else that you did. I have endometriosis and a previous surgery done by you for the endo a few years ago. I will be doing IVF at your clinic. Will I need this surgery again before doing a transfer? Anna, I don't know. I'd have to see you. Gia, can I have a consult with you this week if I'm from Australia? How does the costing work for a consult? I think we charge either 200 or 250 Canadian dollars. This week's tight because I'm going to Denmark tomorrow. But I could maybe squeeze you in on next week sometime. Just ask the office and they'll get you in as quickly as possible. No guarantees, and don't get me in trouble. They'll scream at me if I say I can get you in and then they can't. Denmark, yes, someone wrote Denmark. Oh, you didn't know I was going? Oh, that's you. Tarek's texting me. Yeah, I'm going to Denmark tomorrow for 2 days, and then I'm back on Saturday. It's a conference.
I'm officially jealous. Officially jealous.
Hey, dude, you were in Turkey a month ago. That was cool too. I would have gone.
Yeah, no, that was all right.
Oh, can you explain? Oh, wait. I'm 33 years old. Had a miscarriage since 06. Since 6 months ago. However, we have been trying again, but no pregnancy yet. Can we do an IVF, or you have other option? We got lots of options, but I need to know what's wrong. You could do vitamins and supplements. We've got ways to improve sperm quality, egg quality. We've got naturopathic options. We've got insemination. We've got IVF. We've got surgery. So there's always options. I need to know what's wrong with you. So that's a great question, but I need details. Can you explain why no low-dose HCG? Do you recommend Menopur instead, or what would you do? Yeah, we do recommend Menopur. Low-dose HCG has not been proven to improve outcomes in anybody, so we don't do it. Have you had patients not respond well to letrozole? Yes. The one mini IVF cycle I did with it, my body didn't respond, but I seemed to do okay with Clomid. Yep. No, you can try Clomid instead of letrozole. There's no data that shows that in mini stims or low-dose protocols or anything like that, that one is better than the other. So either one is perfectly fine. You're good with either one of those. I think I actually managed to answer all the questions. That was like super rapid fire. Okay, guys. So thank you for watching and for your attention. We love you all. I hope you guys all have a great week. Wish me luck in Denmark. And we're going to mix some business and entertainment and stuff in there as well. So we'll let you guys know how things go. Next week, we'll probably review the article on progesterone levels in endometriosis. So stay tuned for that as well. And hopefully that'll be meaningful for you all. I'm not sure what's going on in the background, but there's noise from Tarek's end. Okay, have a good night, guys. Tarek, we are going to shut it down now. Take care, everybody. See you later next week on Fertility Factor.